Before we had any meaningful breast imaging at all, physicians already recognized the crucial need to have imaging source in order to eliminate breast cancer mortality. It all started in 1924 when Dr. Clapton made a concerning report to his colleagues at the annual meeting of Radiologic Society of North America. He stated that whatever methods they were using back then, which was pretty much palpation of the breast tissue, was not enough, and it had certain limitations to diagnosis. So therefore, they needed to come up with some kind of imaging modality. Although radiographic examinations were already practiced at that time, however, the radiography of breast tissue was not a common practice because of poor image quality. Direct exposure mammography was the first utilized method in breast imaging. With direct exposure, an industrial film was used, and this method required long exposure times. Because of that, you would actually have kind of blurry images, but it was the best that they had at that time. The idea originated in 1930 from Dr. Warren's case study, where he took 119 patients. He used direct exposure mammography in cancer diagnostics, and only 8 out of 119 were misclassified, which presented an amazing diagnostic accuracy of 93%. Because of such a success in diagnostics, this method became the first official breast imaging source available in a healthcare setting. In 1950, additional modality came out for breast screening. It was called thermography. Thermography was used to create temperature map of breasts on the basis of infrared radiation, assuming that breast cancers would have higher temperatures due to higher metabolic activity when compared to the other breast tissues. Unfortunately, thermography proved to be less sensitive when compared to regular mammography. Interestingly enough, thermography is still used for breast cancer detection until this day, but FDA warns patients that it is not a viable standalone tool for breast screening, and it should not be used instead of mammography. In early 1970s, another method became really popular for breast imaging known as zero mammography. This type of imaging process required more radiation exposure, and the images were printed on paper with the application of blue xerographic powder. This method presented inverted contrast where the breast tissue and the masses appeared dark, while the fatty portion of the breast would appear light on the xerograms. This wasn't really favored by the physicians, along with many other processing issues such as jams and non-uniform toners that were used. So because of lack of innovation and significant increase in radiation exposure, additional advancement was made in 1972, switching to screen film mammography, where a more collimated X-ray beam was utilized, projecting through the breast into a cassette that was containing a film, which further had to be processed in a dark room. With film screening method, a breast compression technique was also utilized to visualize uniform thickness of the breast tissue. This method dramatically reduced radiation exposure, which eventually completely replaced the previously mentioned methods such as direct exposure and zero mammography. Transitioning to digital mammography was another major change in early 2000s. In this method, the radiation capturing device was an electronic image detector instead of a film, where a lot less radiation was needed to produce an image, which also meant a lot less radiation to the patient. However, there are some pros and cons to this method, although analysis revealed that digital mammography did not perform as well as film in older women with fatty breasts, but proved to have more diagnostic accuracy with women younger than 50, where perimenopausal, premenopausal, and women with heterogeneously dense breast tissues had better diagnostic value. Additional advantages of converting to digital mammography meant no more lost films, lower radiation dose, faster examinations, and integration of electronic medical records. And that brings us to the most advanced technological transition that took place in 2011, and it is called digital breast tomosynthesis. Now, this technology acquires multiple low-dose projections obtained from different angles, where produced exposures are then formulated into digital data that can be arranged to create a 3D image of the breast. Now, this actually allows us to visualize the breast from different perspectives without superimposition of other tissues. As of today, this is considered to be the most effective diagnostic method in early breast cancer detection.
Why has digital breast tomosynthesis, or TOMO for slang, so beneficial for detecting breast cancer? Digital breast TOMO increases patient outcome effectiveness with a reduced radiation dose. The advancement of the technology showed an increase in cancer detection and a decrease in recalls, which can happen more frequently with 2D digital mammography and is more prominent in women with dense breast tissue. The main advantage of digital breast TOMO compared to 2D imaging is the practical ability to detect lesions precisely in size, location, and characterization. It was interesting to learn that TOMO, or 3D imaging, is used in conjunction with 2D imaging. The FDA has approved modifications in TOMO to include a synthesized 2D mammography that keeps within the philosophy of ALARA. Because TOMO takes images in layers of the breast similar to CT, it allows for a better view of the breast and finding the exact placement of a lesion. The machine works by moving an arch rotation from medial to lateral. When the exposure is made, 15 images are created. The tube will stop its vertical starting position and then take a 2D image. Once the radiologist reads each layer image, the exam can be read in a 2D composition.
We had the opportunity to spend a few hours with these lovely mammographers at Kaiser Permanente Vacaville Hospital, which only provides routine screening mammography, with each lady coming from different periods of technological progression. We had a true autobiography of the history of technological advancements in mammography. Mary, also the lead in mammo, has been a mammo technologist for 30 years. As a student, she came into the program as the zero mammography was phasing out, for which she was grateful. As she put it, what a mess. In her opinion, the most significant progression in mammography was the patient care that compression technology provided. It started with a manual release to keep the woman's breasts compressed until the technologist could release them. Now, with digital mammography, the machine automatically removes the woman from compression as soon as the exposure is made. Monica became a mammo technologist using film screen. She explained it was time-consuming and cumbersome, having to hang multiple images on a reader box and have the doctor scroll for each image. Alicia, the young one, as the other ladies described her, has been a technologist since 2012 and started in Redwood City, Kaiser Permanente. She has seen a significant change in the progression of technology. She began on indirect digital CR and progressed into digital mammography and has even been trained on TOMO. In addition to working at Kaiser Permanente, she also worked at Sutter, where she could work directly with TOMO. She was enthusiastic about TOMO and hopes that soon Kaiser Permanente too will offer 3D imaging to their patients. We were given a tour of 2 exam rooms at Kaiser Permanente Vacaville. The first room is an older model, which is a General Electric. Though is functional, all technologists preferred the second room. The Hologic is a more user-friendly machine. It was interesting to learn that it is ready for TOMO, but it just needs the equipment attachment and the necessary software added. Alicia started to go into more depth about TOMO. It does take more compression than 2D mammography. Any breathing or any movement will affect the image, so more compression is necessary. There are 4 different categories for TOMO. The first is 2D, there's 3D standalone, and a C-view TOMO, which takes 20 images and then a 3D image. The last category is stereo. It can be used for biopsy. She explained that the only real downfall of TOMO is that it cannot see calcifications very well, which is why most radiologists' protocol is TOMO with 2D. When we asked her her opinion as to why Kaiser Permanente has yet to move to TOMO as quickly as other healthcare providers, she explained it takes time to create protocols, and the providers have to have a desire to learn a new skill set of reading TOMO. She further explained at one health institute where she used to work, a lawsuit was filed due to discrimination. It was the radiologist's protocol that if a woman was over a certain BMI, they would not be offered TOMO, as their breasts were more pronounced and would be more demanding, more slices for the radiologist to read. If a patient does have a callback, she will be referred to a diagnostic center like Kaiser Permanente South Sacramento.
Kaiser Permanente in South Sacramento is a breast center offering diagnostic, screening, biopsy, and mammolocalization. Mammolocalization is when the doctor inserts a seed or wire into the area of concern to prepare for surgical biopsy. Also, another benefit of breast centers is that the radiologists are reading in real time, providing immediate results to the patient. Furthermore, due to the advancements in technology, mammolocalization is slowly phasing out and is being replaced with the inclusion of fusing two modalities such as MRI and ultrasound with mammography biopsies. The benefits of these inclusive advancements are that women are able to avoid invasive surgery, a faster outcome, and is more efficient for the patient.
Lauren, what is your supervision of breast tomography?
Hi, Lisa. I'm so glad you asked. After further research and thorough interviews with multiple mammographers, I feel that the technology with screening and diagnostic imaging will not advance. The technology of 3D imaging has hit its peak, but the future and growth of the technology within the field is fusing other modalities such as MRI, CT, ultrasound to allow for advancement in patient care, both diagnostic purposes and comfortability. Now, Lisa, I must ask, what is your supervision of breast tomography?
Kaiser Permanente is already using CAD, or computer assisted detection. It uses specially designed software to analyze mammography images. I feel that AI is the next step in technology improvements. AI is evolving quickly, and new and different studies are being created to assess its ability to detect breast cancer. One interesting challenge is AI needs to create all-inclusive, heterogeneous data. It is imperative to include not only the data on dense breast tissue characteristics, but also racially diverse characteristics of breast tissue. G, what is your supervision of breast tomography?
As we look forward to future possibilities in breast imaging, medical engineers continuously work on developing new modalities and methods that are primarily focusing on 4 different aspects. Number 1 is to create a better visualization of cancer lesions. 2, improve early detection. 3, improve visualization of cancers in dense breast tissue, which is crucial, and that is because 50% of cancers are getting missed in patients with dense breast tissue when using mammography. And last but not least is reduction of radiation exposure to a minimum. So with that being said, allow me to introduce a new imaging modality that has a great potential in dominating the future of breast imaging. It is called the SoftView. SoftView is a 3D ultrasound breast tomography. And I think the name SoftView fits this modality perfectly. First of all, because it doesn't require any breast compression and it eliminated the use of ionizing radiation. The way the scanning process goes, the patient simply lies on the imaging table where the breast is placed into a chamber that is filled with warm water. Then, incorporated circular ultrasound transducer surrounds the breast and it advances from the nipple towards the breast wall, capturing the transmitted and reflected ultrasound signals using 360-degree sequencing. Then this data is processed by different algorithms that formulate image layers and coronal planes. And they're delivered in 4 different sequences called wafer, sound speed, reflection, and stiffness fusion. With such application, it allows visualization of anatomic and physiologic properties of breast tissue. This interesting technology was developed by Karmanos Cancer Institute and Delphinus Medical Technologies. It was first placed through laboratory trials in August 2012, where it was initially used on phantoms, and later on it was tested on human subjects. So far, comparing this ultrasound breast tomography method to digital mammography, it showed a 20% increase in cancer detection sensibility, especially when it comes to patients with dense breast tissue. And it also showed an 8% increase in specificity, reducing the number of false positive results. In October 6, 2021, SoftView received a pre-market approval by FDA, and currently it is going through a substantive review, making sure that it meets the threshold of medical acceptability.